Can we start, madam? Sendil sir, can we start?
Nandakumar doctor, we can
Please
start,
start.
yeah.
This is a 73-year-old female. She is known long-standing diabetes, hypertension. She presented to OPD with history of dizziness and palpitation. She was investigated in OPD. The investigation, whatever was done, was within normal limit. ECG was normal. Echo done was normal. It was seen by cardiologist. He requested for ultrasound neck Doppler. That is also insignificant. There is no minimal atherosclerotic changes were there. When she was going back home, she had chest heaviness and followed by uneasiness, followed by unresponsiveness. So she returned back to our hospital. On the way, she was unresponsive. Bystanders not provided CPR. When arrival to the hospital, initial rhythm was non-shockable rhythm, followed by it was a shockable rhythm. Total duration of CPR was 20 minutes. The 10th cycle was undergone. During CPR, she had both shockable rhythm and non-shockable rhythm. 2 doses of amiodarone and 5 doses of epinephrine, and reversible causes clear. The recoverable cause was not identified. So after return of spontaneous circulation, so immediate ABG showed pH is 7.0. PO2 is around 38.6, PaCO2 is 68, bicarb is 19.1, ABG showed hypokalemia, other lactate was 8.85. During this time, because the duration of CPR, initial rhythm was non-shockable rhythm and bystanders not provided CPR. During that time, during the emergency, there is a scoring system is available. It's only 2 scoring system. Is one of out of hospital cardiac arrest scoring system. One is a cardiac arrest survival prognosis scoring system. In that scoring system, it came is a score. Out of hospital cardiac arrest scores are 0 to 100. More than 50 is tells there is a prognosis for 30 days mortality is very high. For this patient, is very high score. So we prognosticated and during that time, the blood pressure was very low, supported with dual vasopressors, and patient agreed for the treatment. So shifted the patient to the ICU. The emergency ECG showed there is a junctional rhythm. There is no P waves are not there. There is an ST depressions were there in V2 to V5. So echo was done that time. It was ejection fraction is 50%. No regional water motion abnormality. Patient was shifted to ICU. The pupils are very small size, sluggish reacting to light. M1 response. She was on controlled ventilation. The oxygen pulse oximeters wouldn't detect properly. So we kept on 80% of FiO2. The vitals were supported with dual vasopressor support. Invasive lines were placed. Repeat ECG showed normalized pH with low bicarbonate 14.6. PO2 was very high. So we decreased FiO2 to 50%. During that time, there is mild increase in potassium because during the emergency, they started potassium correction. It was going on. The repeat lactate was increasing from 8, it increased to 12.16. So because of considering low GCS, we started when therapeutic temperature management was started.
Dr. Nandakumar,
Yes, sir.
you told she had both the shockable and non-shockable rhythms.
Yes, sir.
Is there any difference in the outcome?
So all scoring system, it is a shockable rhythm means there is a prognosis little bit better because the numbers are little higher side when it is a non-shockable rhythm. So all non-shockable rhythm numbers going, it increases the number. So non-shockable rhythm means prognosis is little bit bad compared to a shockable rhythm.
Okay, yeah, you can continue.
In ICU, ECG was taken. ECG shows there is a sinus rhythm. In emergency, it showed there is a junctional rhythm. Now it has become normal rhythm, normal sinus rhythm. There is an RBB was there. The incomplete RBB was there, V1 to V3. There is mild STT changes were there in the V1 to V4. During this time, cardiologist also with us, he was there. So we discussed, we plan to do an angiogram. So during that time, cardiologist asked to rule out the CNS calls also. So because of that, we done in a CT brain. CT brain, there is no edema, there is no bleed. It's very difficult to tell the infarct in the early picture. There is no bleed or there is no cerebral edema in the CT scan. So we gone ahead with an CAG, coronary angiogram. In coronary angiogram, during the procedure itself, she had ventricular fibrillation. One sharp defibrillation was given. That time CAG showed the LAD was culprit vessels. There is a 70 to 80% lesion was there. But even with lesion, there is a TIMI3 flow was there. So he decided not to go do a stent or balloon dilatation because the TIMI3 flow was there. So it planned for an conservative management with antiplatelet statin and heparin. It was started in the emergency itself. The heparin was given during the angiogram and it was shifted back to an ICU. The day one investigation showed there is initial potassium was low. It was corrected with 20 milligrams of KCl. After that, it was normalized. Other investigations other than lactate, other than potassium, other investigations were normal. Initial, there is a mild liver enzymes were there because due to the ischemic hepatitis. Here the cause would have been mostly ischemia or arrhythmias would have been precipitated for an cardiac arrest. Day one, she had remained to be a low GCS. We are treated with a minimal dose of dexmedetomidine because vitals were a little bit better. So we started with a low dose of dexmedetomidine. Oxygenation stable with control ventilation. Shock was better. Very minimal dose of norepinephrine. It started increase to 12. Then after that, it started decreasing. Continue because of hypothermia. We started with continuous EEG monitoring. The day 1 to day 2, the myoclonic status treated with midazolam bolus followed by a 10 milligram per hour infusion. Along with brivaracetam and clobazam was started by a neurologist. The continuous EEG is also shows initial period there is an epileptic activity was there. So midazolam mildly increase escalated to 15 milligram per hour. This is the EEG shows there is a generalized periodic discharge throughout the cycle. During that time, even that time, there was a lactate was decreasing trend. The day 1 to day 2, there was a mild, there is an acidosis was there. That time there is an sugars were little on higher side. The serum ketone was little high and there is a lactate was decreasing trend. So treated like a DKA with hydration and with insulin infusion. So during the same day, within a few hours of infusion, there is a generalized slowing of activities. There is a generalized suppression pattern was there. By seeing this ECG, we started, there is a no clinical seizure also was there. So we started tapering midazolam, tapped and stopped within 1.5 days durations. During that time, people were reacting, cornea was intact. She was remained to be extension to pain. The vitals were very stable with very minimal dose of norepinephrine. Oxygenation also was stable with control ventilation. So we
Dr.
planned.
Nandakumar,
Yes, sir.
see, you told on day one she had myoclonic status.
Yes, sir. Myoclonic jugs were there.
Okay.
It was treated with midazolam infusion, midazolam bolus followed by infusion. So
Okay.
during that time, we started on brivaracetam with clobazam because clobazam have long acting half-life. When even the midazolam was stopped, it can be a prolonged action will be there because of that neurologist started with clobazam.
Okay. Can you prognosticate for such a patient who has got myoclonic jerks on day one?
So within 24 hours, the myoclonic jerks is not a predictor of a poor outcome.
Okay.
So it was persisting for 2 or 3 days. With even the EEG was showing the status epilepticus, then we can prognosticate. Only in the day 1 of status myoclonus, we should not prognosticate.
Okay. Continue. Yeah.
So after 3 or 4 days, the generalized she is remained to be a low GCS and people were reacting and EEG shows generalized suppression pattern. So we decided to, because to prognosticate, to see for an MRI, because MRI is recommended to do 2 to 5 days. So we done an MRI scan. The MRI scan shows the diffuse weighted imaging. In diffuse weighted imaging, you can see there is an hyperintensity in the cerebellum, more towards the left side. Bilateral cerebellar hyperintensity was there. Both occipital, bilateral occipital, and more towards the left occipital hyperintensity was there. If you see in upper cut in the cortex, bilateral cardiac nucleus, bilateral capsular ganglion region, there is a significant hyperintensity was there. Same thing we done an ADC comparison. In ADC, there is a bilateral hypodensity was there in the cardiac nucleus and in the capsular ganglion region, in the occipital region. The ADC was apparent diffusion coefficient was less than 615 in both areas, in both the capsular ganglion region and bilateral cerebellar region. It denotes as one of the poorest prognosticator. So impression also was the diffused T2 imaging and FLAR, there's one hyperintensity in the cortex of the bilateral cerebral hemisphere, predominantly left parietal and occipital region, both capsular ganglion and bilateral cerebellar region. It was suggestive of hypoxic ischemic encephalopathy. The next day we had done an EEG. EEG shows slowing of activity throughout the EEG. So we stopped relaxation after we stopped sedation after 48 hours of stopping the sedation. That time GCS persisted to be M1 response, M2 to M2 response. People were reacting to like cornea was intact, no status myoclonus, the stable oxygenation vitals, EEG shows no seizure, there is a generalized slowing of activity was there. MRI, diffuse weighted imaging, ADC, there is a comparison, so diffuse restriction with ADC changes were there in capsular ganglion region and both cortex and deeper nuclei like cardiac nucleus and in the capsular ganglion regions, not in the thalamus. So during this time, we prognosticated to the family because already daily counseling period, we prognosticated to the family. Here the multidisciplinary team meeting was done. The current clinical status and possible outcome was discussed. The current prognosis, because due to the cytotoxic edema in the MRI, sometimes it can progress to the increase in mortality, have been clearly explained to the family. Long-term prognosis, likelihood of severe neurological impairment, she may be in the dependent functional status also has been explained. The cost implication also explained. End of life care options have been discussed. So the patient's previous any wish and family wishes have been discussed with the family, and we told that we may be repeating the MRI only for the prognostication, and if they want to prolonging the care, tracheostomy need has also been explained to the family.
Dr. Nandakumar,
Yes, sir.
What is the role of biomarker in prognostication in such a patient?
So we can do a few biomarkers are there, sir. Neuron specific analysis, because we are not done for that for a patient, but more than 48 hours, we are doing a neuron specific analysis marker. If it was elevated more than 60 microgram per liter, it is one of the significant marker to tell it is a poorer outcome. That also we have to be serial test we have to do. It started increasing on 24th, within a day, it started increasing up to 72 hours. So if the trend is increasing, if the marker is more than 60 microgram per liter, it is one of the marker to tell it is a poorer prognostic, poorer neurological outcome.
Okay.
But there can be a patient should not have hemolysis or neuroendocrine tumor should not be there. If anything, there is a co-founder is there, we can do neurofilamentous light chain we can do so.
Okay.
So we have done a repeat MRI. MRI, there is a new hyperintensity was there in the temporal and parietal region, and there is a corona radiata, and also there is a corona radiata and also corpus callosum, both genu and there is a spleen of corpus callosum, there is a hyperintensity was there. Same thing, it was changes were noted in the ADC mapping also. There is a bilateral, there is both genu and spleen of corpus callosum, and in the corona radiata there is an black color thing. Black color is the hypo intensity was there in ADC mapping. So the old changes were little bit was a decreasing trend because due to that it's becoming super normalization. The new changes were there in the corpus callosum and corona radiata, and also there is a small pedicle hemorrhages were there in the left posterior parietal and high parietal lobe. Again, we had a meeting with the family and we discussed all prognostic signs because this patient had low motor response. EEG showed generalized slowing of activity. MRI brain showed diffuse restricted imaging with ADC reduction. So with this clinical, with EEG, with imaging, the CT and MRI imaging, the suggestive of long-term poor functional outcome has been clearly explained to the family. And she may be remain to be in vegetative state. She may needs a supportive care for the life has been clearly explained to the family. Family decided to continue the care. So we undergone a surgical tracheostomy. She was weaned to track mask and non-invasive ventilation in ICU. After weaning to the tracheal mask and room air, patient was shifted to ward. Currently, she was in more than 2 months of in hospital care with tracheostomy tube. The low GCS, pupils were reacting, all organ function stable. She requiring complete support and assistance last 2 months of hospital stay. Now coming to a neuroprognostication, most of the post-cardiac arrest, more than 50% of patients remains comatose even after 72 hours of the return of spontaneous circulation. Accurate prognosis helps guiding decision about continuing or withdrawing a life-sustained therapy, weighing optimism against reality. Always we have to wait for 72 hours after return of spontaneous circulation and after rewarming before prognostication. Always prognostication has to be done after 72 hours because during the first 72 hours, the patient will be on sedation or patient will be on hypothermia or electrolytes imbalance will be there. That will be difficult to prognosticate during that time. So we have to wait for 72 hours and patient was on hypothermia. After rewarming only, we have to prognosticate to the patient attender. So confounders should be avoided like sedatives, paralytic agents, metabolic derangement and hypothermia must be ruled out. So always with single model approach, you should not be prognosticate. We should have multi-model approach has to be there. The extent observation if prognosis is indeterminate. If the prognosis is not good or not bad, it comes intermediate. We have to consist of the goal of care. We have to continue with the goal of care. We have to maintain throughout their stay in the ICU initial period. We have to maintain the normothermia to improve the accuracy of the assessment. Avoid premature withdrawal of care based on yearly or single finding. So always you should use for neuroprognostication, you should use multimodal approach. So each modality offer a vital insight. When combined, they minimize the chance of premature conclusion and support more accurate clinical judgment. Coming to the first clinical examination. The first clinical examination, we should wait for 72 hours. Even after 72 hours, the return of spontaneous circulation, after rewarming from the therapeutic hypothermia, more than 72 hours, there is a low GCS, the extension to pain, or there is a pupillary reflex and corneal reflex are not intact. Means patient should not be, during this time, patient should not be on sedation or neuromuscular breakdown, hypothermia or electrolytes imbalance should not be there. If there is a low GCS with absence of pupillary and corneal reflex, it is an indicator of the poor prognosis. Only with myoclonus on day 1, you should not prognosticate. If it persists for 2 or 3 days, then we can prognostication is one of the prognosticate indicator. So the clinic, there is a more than 72 hours, there is a no pupillary or corneal reflex, or EEG showing burst suppression pattern, or status myoclonus persisting more than 48 hours. It is an indicator of poor neurological outcome. Is a false positive rate is less than 5%. There is a 95% you will be correct. There is a prognosis going to be bad. During this time, we can, if the patient is having, there is no corneal reflex, no pupillary reflex, there is no gag reflex, so means we can do brain dead certification can be done. If there is a CT scan on the day 1 or day 2, there is a diffuse cerebral edema that is causing herniation, the grave prognosis you can do at that time. If the patient is during that time, day 1, day 2, there is a localizing to pain or withdrawal to pain, it is a favorable prognosis. Otherwise, we have to wait for 72 hours, then only you should prognosticate. Next comes the first is a clinical examination. Next is the electrophysiological study. The main electrophysiological study is an EEG and somatosensory evok potential. In EEG, there is a malignant pattern will be there. Malignant pattern means there is a continuous slowing of activity. That is a generalized bus suppression, suppression pattern will be there. Or bus suppression pattern without stimuli, it will be there. The continuous status epilepticus will be there. Or nearing the flat line, the non-reactive background will be there. These are the malignant pattern of the EEG. In somatosensory evok potential, it is a more, there is a false positive rate, it is very low. If it is a bilateral absence of N20 response, means it is a more towards a poor prognosis. Same thing, there is an after 48 hours, if even with patient is having mild hypothermia or sedation, when you're doing a somatosensory evok potential, when there is an absence of N20 response in cortex, it is a significant marker of poor neurological outcome. The false positivity rate is 0%. That is 99% there is a recovery is unlikely. Next comes in biomarker. So we already discussed, always biomarker has to be done after 48 to 72 hours. If it was elevated or rising trend during the initial period, it is one of the prognostic marker to tell the poorer prognosis. So there are two markers. There is a neurons, multiple markers are there. One is the significance for neuron specific analysis. It is for a neuronal damage. Other neuronal damages, ubiquitous C-terminal hydrolase L1. This two for neuronal injury. The more significant is neuron specific analysis. Neuron specific analysis, there is a co-founders will be a hemolysis. If the patient is on hemolytic anemia, or patient is on hemolysis, a patient is a neuroendocrine tumor, there can be false rise can be there. If it was absence of hemolysis, absence of neuroendocrine tumor, if there is a rise in neuron specific analysis, is an indicator of poor prognosis. If we are not able, because after a week duration, neuron specific analysis will start decreasing trend. But neurofilament light chain is an axonal injury. Other axonal injury marker is tau protein. There is a normal neurofilamentous light chain is more than 160 picogram per ml itself, a significant total injury. The cutoff is more than 400 picogram per ml. It is a significant to tell a poor neurological outcome. Yes, 100B is there for mainly for astrocyte injury. Another neuroimaging will be the CT scan. So first scan we can do scan within 24 hours. CT can be done within 24 hours. Always to prognosticate when there is a loss of gray-white matter differentiation. The MRI, already we discussed, there is a restriction diffusion is there in the cortex or deep nuclei or in the cerebellum or in thalamus. It's one of the indicator of poor prognosis. MRI is more sensitive than CT, but may be limited by patient instability or assessor. So in CT scan, what you want to see will be a gray-white matter ratio. The gray-white matter ratio is, so we have to density of the gray matter. That is density of gray matter in the caudate nucleus and in the putamen. You should take how much the Hansfeld unit is taken in the gray matter density divided by white matter density, that is in the posterior limb of internal capsule and corpus callosum.
Okay,
It is a
I
white.
found this on the web for density. Density is in the costal limb of internal capsule. Check it out.
So when there is an normal value will be more than 1.2. When it decreases to less than 1.2, it indicates a poorer prognosis. Already we discussed MRI. We have to do a diffuse weighted imaging with ADC. We have to compare the diffuse weighted imaging with ADC. There is a diffuse weighted imaging. There will be a hyper intensity is there made in the cerebral cortex, deep nuclei and in the cerebellum. same changes. There will be hypodensity will be there in the ADC mapping. So when you do, the software is there in the packs or in the module itself, MRI module itself, it will calculate. Normal ADC will be more than 700 and more than 800, 700 to 800. When it drops less than 650, it tells there is an irreversible damage is going to be there. Next comes an automated pupillometer. There is when you are not able to clearly check the pupillometry, that time you can use an automated pupillometer. In that automated pupillometer, there is a neurological pupillary index is there. It will measure normal size of the pupil and constricted size of the pupil. The average in the percentage will be there. And there is a constriction velocity of the dilatation velocity and latency will be measured. In that it will be scored as 0 to 5. When the score comes less than 2, it is an abnormal, strongly associated with poor neurological outcome. Now comes the multiple scoring system is there. So when and where the scoring system should be used, we will see. So one of the scoring system is out of hospital scoring system, the Swedish scoring system. It is done in the pre-hospital and in the emergency. The scoring system will includes the age of the patient, witnessed arrest or bystander, they done a CPR not a initial rhythm or time to return of spontaneous circulation. When the score is very high, it denotes the survival is less likely. This is a 30-day survival. So we are going, this is only 5 parameters that is done in the emergency. If the age is high or patient is unwitnessed arrest or bystander not in a CPR, the initial rhythm is a non-shockable rhythm. The time to return of spontaneous circulation, that is a low flow period is more. It indicates the high risk, the score is high. It indicates that the survival, 30-day survival is less likely. Our patient score was 74. The 30 days mortality is very high, but patient mortality was not there. So mostly in scoring system, the used scoring system was CPC scoring system. CPC scoring system, cerebral performance category scale. 1 and 2 is one is a full recovery to mild disability. 2 is moderate disability but independence in activity of daily living. 3 is severe disability needing support for all daily activity. 4 is a persistent vegetative state and 5 is a death. 3 to 5 indicates a negative outcome. 1 to 2 indicates a positive outcome. First score we have seen is out of hospital cardiac arrest. This is done in the emergency. Next comes an cardiac arrest hospital prognosis score. Is done in the admission and after 24 hours. So the scoring system, it includes age, initial rhythm, no flow period. No flow period means it's the outside arrest. There is no one done a CPR. Yeah, done a CPR. There is a duration. That is includes no flow time. Low flow time is during the CPR. The duration of CPR is the low flow time. Here epinephrine used or not, pH on admission. Extra you are there from that to here is an pH was there, and after 24 hours, what is the motor response? When the score is high, 95% there is a poorer outcome. The positive predictive value 90%, they will not make it. This is a long-term outcome. Our patient score was 190. So 95% is a poorer outcome. CPC score is going to be high. Next comes because our patient, we used the temperature, target temperature management. So 2 scoring system for TTM, 2TM. One is for TTM score, one is a Miracle 2 trial. One is they include age, initial rhythm, time to return of spontaneous circulation. Here they used pupillary reflex and corneal reflex and neuron specific analysis at 48 hours. So when the score is more than 24, indicates a poorer prognosis. Our patient score was 47. It indicates the 90% there is going to be in a dependent state. Next is a Miracle 2. This is also post targeted temperature management. This is also done 24 to 48 hours. Out of hospital cardiac arrest score is done at the emergency, and cardiac arrest survival prognosis score is done in the emergency at 24 hours. And Miracle and TTM is done after 48 hours of TTM. Here, Miracle 2 study, they ask only yes or no. This is a good prognosis, to tell for a good prognosis. The patient have motor response is there, means that is a good. Next, everything will be yes or no question. Initial rhythm is shockable rhythm means yes. There is a return of spontaneous circulation less than 30 minutes means yes. Age less than 65. Cardiac cause of arrest. Lactate is less than 5. EEG is reactive. It comes yes or no. Yes comes 1. If the score is more, the high chance patient will survive. There is a low score. There is a low chance of good recovery will be there. So our patient have only 3 score. So there is a low chance of good recovery. Then one more is the null P score. Null means N for non-shockable rhythm. Every parameter is once the score is 1 is calculated. So it is N for non-shockable rhythm. It is done. Generally, the score is done for more than 72 hours. It is for neuroprognostication. One is unwitnessed arrest. One is L, I told for long low flow period. It is a no one done a CPR. There is a no flow period. One is a low flow period during CPR. So I written wrongly. pH is less than 7.2. Lactate is more than 7. So end stage renal disease. Creatinine is more than 2. Age is more than 80. Or 72 hours, still patient is unconscious. If the score is more than 5, it tells the 95% is a poorer outcome. So our patient score is 6. So it's predicted the poorer outcome. These are the comparison of the all scores. Out of hospital cardiac arrest score is done in emergency and pre-hospital. And CAHP score, this is a cardiac arrest hospital prognosis score is done at the admission in 24 hours because GCS is measured during that time. So Miracle score and TTM is measured at 48 hours. This is both for after TTM. Null piece is done for more than 72 hours. So this is the basic approach we have to do. So always when the patient is having post cardiac arrest, we should wait for 72 hours of post return of spontaneous circulation and after rewarming. Always your confounders should be ruled out. Stepwise approach you should do. GCS, pupillary reflex, EEG, somatosensory evoked potential, neuron specific analysis trend, imaging. If more than 2 strong predictor of poorer outcome, high likely to be an unfavorable recovery. You have to communicate with family and team before any decision. So these are the timing we have to do. Pupillary reflex and coronal reflex has to be done more than 72 hours. If bilaterally absent, it is one of the poorer indicator. I told somatosensory evoked potential is done more than 24 hours. Bilateral absence of N20 response, it is a clearly it can tell the false positive predictive rate is less than 1%. The 99% patient will not recover. EEG, there is a malignant EEG is there. There is an generalized suppression, burst suppression without reactivity, or there is a generalized periodic activity is there. These are tells the malignant EEG. And on neuron specific analysis, when the trend is increasing after 48 hours, it is one of the poorer prognosis. CT brain, there is a loss of gray-white matter differentiation. It tells a poorer prognosis. MRI should be done in 2 to 7 days. There is an extensive involvement in the cortex, deep nuclei and cerebellum. This indicates a poorer prognosis. So always we should use 2 or more indicator consistently suggest poorer prognosis. Timing is appropriate and confounders should be excluded. Decisions are made with family involvement and aligned with goal of care. Thank you.
Dr. Nandakumar, that was an extensive presentation, lot of scoring systems.
Yes, sir.
Yeah, so to all the students, the basic things we have to see is normally the prognostication should not be done early. That is the main point here. So you should wait for at least more than or equal to 72 hours post ROIC and then after rewarming. Main thing will be assess for the confounding factors here, especially any drugs, intoxication, hypothermia, metabolic derangements, all these things we have to definitely rule out before coming to a conclusion. And as Dr. Nandakumar was telling, their stepwise approach will be helpful. So look for the pupils, corneal reflex. You see the somatosensory evoked potential, EEG, then see for the neuron-specific enolase. This neuron-specific enolase has got a specificity of more than 95%. So, and after that, you can go for a imaging, CTRI, MRI. And if there are more than 2 strong predictors of poor outcome, then it looks like the patient is going to have an unfavorable recovery, and we have to correctly communicate with the patient family and then come to a decision regarding whether to continue the treatment or not. Madam, you can give your inputs. Yeah.
I said it's an excellent presentation. Can I ask Adira one question? Adira, you are on. Adira?
Ma'am?
Yeah. So from this presentation, if you were to prognosticate to a family
Okay, ma'am.
who's financing for this patient on their own,
Okay, ma'am.
and they say you told them 48 hours, 72 hours, we have to wait and only then we can make a decision. And
Okay,
that
ma'am.
family says we have to kind of sell all our properties to keep for another 24 hours. What will
Ma'am.
you give your opinion? So what will you say?
Ma'am, as per guidelines, I will explain that as per guidelines, we have to wait for 72 hours and post cardiac arrest and after rewarming. Then it's a tricky situation, ma'am. I don't want them to sell the properties.
Exactly.
For
So
apparently,
what is the prognostication we are giving? Is it functional outcome? Is it life? What are we prognosticating for?
patient may survive, ma'am, but without much functional outcome.
Correct. He is going to be definitely not able to.
He may he or she may survive, but without being functional. So
correct.
I will explain that to them.
So you have to remember all these guidelines. You have to kind of alter it for our needs. If it is someone who's going to sell everything and keep for 24 hours for you to prognosticate and say, oh, okay, now there's no point, that is not fair. So at the upfront, when you're saying I can only prognosticate, you have to make it very clear what are you prognosticating for. At the end of it, he might be a vegetative person, not going to earn for himself and look after himself. That has to be made clear upfront. India is a very dynamic country. There might be many others who want the patient to be just alive to give a thumbprint and life goes on.
Okay, ma'am.
That kind of people, it is okay.
Okay,
for someone who wants an earning member of family, this may not be okay. So that aspect, none of the Western guidelines will give you. You have to tailor it for your local requirement.
Okay, ma'am.
Otherwise, it was Nandakumar, wonderful presentation, a lot of new learnings. You should have probably put curing coma campaign, some reference. That would have been excellent. That is our own material, so we should try and promote it as much as we can.
Okay.
Any other student wants to clarify something, please do. Okay, otherwise, Nandakumar, thank you very much. Dr. Senthil, nice coordination, well asked questions. Nobody was sleeping. It was very interesting. Thank you very much.
Nandakumar keeps everyone on tenterhooks, ma'am. Even in ICU, the same thing happens.
First of all, to keep pace with his speech, you have to be fully alert.
True, ma'am. True.
Thank you very much.
Thank you.
Thank you,
Good
ma'am.
night. See you
Thank
soon.
you. Good night.
You